Morning, everyone. 2 weeks to Christmas. I got whammed yesterday by my daughter. I've been trying to avoid it, and then the Christmas radio in the car, and then that was it. So, there we go. Mind you, I like that song. I don't mind. Um, I find the whole Whamageddon thing quite funny. I don't know whether you heard there was a DJ played it at halftime at a rugby match, and there was about 7,000 people complained. I didn't even know it existed until this week. But there we go, behind the times. Good morning, Martin. Right. Good morning, Becky. Morning, Tris. Yeah, I was going to play some Christmassy music at the beginning, but then I don't know, with being on YouTube and all that kind of stuff, all the copyright issues that go along with music. I don't know. I don't think I should. Got whammed on December the 1st. Blimey, that's an early one. First day of December. Right. Let's get going. This is where we finished. So yeah, warbled on for a while about the meniscus. Let's do this one first. Actually, let's remind ourselves of what we're talking about. Everything's going a bit slow today. Right. So this is where we were. So we were talking about the tibial plateau, and then the meniscus that then sit on the top. So let's just play that through first of all. Just get rid of that. There we go. You can see better. Okay, and yeah, there's the meniscus sitting on top. So yeah, everything's really slow. Sorry. So we've got this side here, which is your fibula. So that would be the lateral meniscus. And you see that's more of a C shape. Sorry, more of an O shape, and then more of a C shape on this lateral side. Obviously, the C the other way around. And there's a really strong attachment on that posterior aspect of the medial meniscus, which is going to be important for later. There we go. So yeah, that's the structure of everything. So we were looking at that the other week, where it's what we call a concave structure. So where something's bigger on the outside and then smaller on the inside. Yeah, they've got wider edge points, and we were looking at the histology of those, what is in those as well. So yeah, they attach to the interarticular notch in the middle there. So there and there. Yeah, so medial attachments far apart, so that's why it's more like a C shape, and then the lateral attachments closer together, that's why it's more like an O, like a donut. Yeah, and then you've got capsular attachments as well, but more so on that medial aspect. So the capsule kind of merges into that medial side. Here we go. So you can see it's really quite attached in there. It's like it's one. Okay, so really strong attachment medially. So that's why you often get the dual injuries to the medial meniscus and the medial collateral ligament, because of the attachments there. There we go. So this is the mobility of them. So the lateral meniscus is quite mobile, whereas the medial is not so mobile. And again, the structure of it, it said it doesn't move. It does move, but not as much as the lateral side. So they both do move, and they need to, because of the movement of the femur on top of the tibia. So especially during rotation. So if you rotate with a flex knee, then the meniscus will move with you, or should do anyway. So that's where that's where we kind of finished. This was the summary of that. So medial meniscus larger than the lateral, C shaped, but obviously like a inverted C, or a back to front C. So what we call semi-lunar. So half like half moon shaped. Okay, thick posteriorly, thinner anteriorly. So it's got a bit where it attaches posteriorly, the meniscus is thicker on the medial side, more firmly attached to the tibia, as we saw. So so it did move, but not as freely as the lateral side. The anterior horn, which is the front part of the meniscus, attaches to the anterior intercondylar area. So you've got those two plateaus, and the medial meniscus will attach at the front of the medial side, anterior to the ACL, so just in front of your anterior cruciate ligament, which is what we saw last week. The posterior horn attaches to the posterior intercondylar area, and it's in front of, so anterior to the PCL, which is the posterior cruciate ligament, attaches to the MCL and to the semimembranosus as well. Okay, so we've got quite, it's a real kind of like converging point of a lot of structures on that medial aspect of the knee. The lateral meniscus, smaller than the medial, 4/5 of a circle, so it's nearly fully circular. Equal thickness throughout, so there's no thicker areas at the back. The anterior horn attaches to the intercondylar area again, next to the ACL, and then the posterior horn attaches to the posterior intercondylar area next to the posterior horn of the medial meniscus. So they attach quite close together at the back. And then the muscular kind of merging is with the popliteus muscle, which we may get onto today. We'll see how we go. So you've got the popliteus muscle at the back there. So that's a nice little summary of both meniscus. But one where if you're, let me just move me out of the way so I'm not covering everything. So one, if you're doing some revision, take a screenshot, and then those are the kind of things that you that would be useful to know. This is another good one. So it's predominantly type 1 collagen, the meniscus. 90% of collagen content is type 1. The collagen bundles are arranged in circumferential patterns, optimal for absorption of compressive loads. So if we see, we've got these lines in here that you can see there and there. So they basically kind of wrap around like a circle, but there are some crisscross elements to it as well. So it's not just circular. Radial fibers are woven between the circumferential fibers, providing structural integrity. Okay, so that here's the radial fibers here. So can you see those there? Yeah, those there. So that circular one there is that's like the cross section of the fibers coming towards you, and then the radial fibers were merging in. Okay, so that kind of crisscross pattern will give it some strength. And I think I mentioned like a jam jar last week. So if you had them all going in one direction and then there was compressive load on it and then it twisted, it would only be able to resist so much of that movement, and then it would just the integrity would be compromised. So the fact that it's got lots of different directions of collagen is part of its strength. So this arrangement enables resistance of hoop stresses produced at the meniscus during weight bearing. So basically, when you load something axially, so from the top down, which obviously you do with your femur, and then you've got the ground coming up and the tibia coming up, it resists those forces by being able to bulge, basically. Okay, so very very similar to discs. Good morning, Penny. Morning, welcome. So here we go. This is a good one. So we've got radial fibers, and then the circumferential fibers, these ones here. So circumferential, basically rounding like a circle, radial crossing them. Okay, so coming in another direction. And what we'll have a look at in a second, I think it's in a couple of slides time, we'll have a look at some of the injuries that you can get with the meniscus. So if you've had a meniscal tear, then usually they give it a name, okay? And we'll have a look at those names in a sec. The meniscus are not static structures, they're mobile. The motion occurs with respect to the tibial plateau, so they move on the plateau. There is an anterior to posterior displacement of the meniscus, and during knee flexion and extension, the lateral meniscus can be displaced by as much as up to 10 millimeters. Okay, and then the medial meniscus up to 5. So they both move. That was a study done a little while ago. It's funny because we kind of criticize studies from ages ago, but some things never change. Okay, so if they've done it and they've done it on enough people, they may want to redo the study, but basically that's what happens to your meniscus. So we don't really need to look at that again. The posterior lateral fibers of the MCL limit the movement of the medial meniscus in rotation, and this may be why there's an increased risk of tear during tibiofemoral rotation. Okay, so because one of the meniscus that gets injured the most is the medial meniscus, and that we think that might be why. Okay, so because of the structure. Deformation of shape to maintain contact, maybe to increase stabilization. Okay, so allowing that deformation of the shape, so being able to absorb forces and move, hopefully helps increase the stabilization of the knee, potentially. Okay, we don't obviously know why it was designed the way it is. So here we are. So these are some of the types of injuries you can get. So that would be a radial tear, which would make sense because of the radial fibers that we were just talking about. So the fibers coming from out to in or in to out, and in that kind of direction. This is a bucket handle tear, because it obviously looks like a bucket handle, and it's this kind of one that usually gets caught. So and people complain of locking of the knee, and because only the outside is innervated, so that's where you get sensation. You can have a bucket handle tear on the inside of the meniscus, and not know that you've got it. The only thing you experience is a locking of the knee. Okay, so and your knee feels a bit weird. Sometimes it can be painful. Don't get me wrong, but yeah, if you have someone whose knee locks and then they kind of have to wiggle it about a bit, and then it's free again, it may be because there's this flap. Okay, so if the flap is down, then it's fine. But if it's flapped up, then it will stop the femur from being able to glide on the tibial plateau. Parrot's beak tear. So that this one here, where it's got a little bit of like a protrusion on the inside again. We've got a horizontal tear, so that's what it would look like. Obviously, you can't see anything here, but cross sectionally, that's what it looked like. So in the middle of it, a tear at the root, okay, and then degenerative tears throughout the meniscus, which are just normal signs of aging. Okay. I had a bucket tear that had also split, so flappers were irritating, causing pain, got shaved off. Yeah, that's usually what happens. Yeah, it depends on how it's impacting you. So sometimes you can get away with it, and it's just a bit annoying. If you're quite young, then they'll usually trim it. But yeah, it depends. Yeah, so because you can live with things like this, no problem at all. For some people, it's incredibly painful or debilitating in terms of function. So then they'll look at operating, because of the impact it's having on your life. Okay, so cool. Right, let's have a look at this. Just see if I've got that there. Yeah, so we had a look at this is the joint capsule. I had a look at this before. So this is your patella just here. It's these videos that are slowing everything down. Okay, everything else is okay. So there's the joint capsule there. I'm just going to move that out of the way and just let it play. So that's attached onto your medial collateral, which we've just been having a look at, and the medial meniscus as well on that inside. And then there's your lateral collateral ligament, so you can see that attaching onto the fibular head. So there it is there. And then there's the capsule. So there's no contact with the capsule there. And then round the back, you can see the joint capsule just here as well. Again, super slow this video today. So thickened at the back to prevent hyperextension. Cool. So that's what your capsule looks like. So inside there is all synovial fluid. So as you move the joint, in fact, you can see it just on here. Look at this. So just as they open up there, you can just see inside, and it's like really glistening on the inside of the joint membrane there. So yeah, but when you move, you produce synovial fluid, which then lubricates that joint capsule, keeps everything nice and healthy. Okay, it's where a lot of the structures inside the capsule get their nutrients from. So literally movement is medicine in that case. Right, so let's have a look at it on here. So this is what it looks like in the books. It extends up quite high, so it extends up all the way up here. And this is the thing where you can get a cyst at the back of the knee called a Baker's cyst. So if you, or a popliteal cyst. So if you have any kind of irritation in the knee, so in the structures in the capsule in the knee, and there's swelling, it will swell, and then eventually it'll be like blowing up a balloon, and then you get that little bit of a balloon that pops out, and that will pop out of the back, and you'll see a lump right at the back here, and that will be a popliteal cyst. Okay, so if you see those, it's usually indicative that there is something that has happened within the knee. Okay, so it's worth obviously going over the history for that person to see if there's anything happened to them that may have affected some structure inside the kneecap, inside the knee joint itself. So largest joint space in the body. It's made up of an external fibrous layer, and then an internal synovial membrane that lines all the internal surfaces that are not covered by the articular cartilage. So, but basically, the capsule envelops everything within that knee space, okay, and lubricates everything. It attaches to the femur superiorly and the tibia inferiorly, but look how far it comes up on the femur. Okay, so there's your kneecap there. So it's coming up way beyond your kneecap. And this is, there is a test you can do that is called a sweep test. And it's where you push fluid into this, this pouch up here, and you then observe to see whether the fluid then pops down into the inside of the knee. So if you've not seen it before, have a look for sweep test. Well, there's loads of versions of sweep test online, but you want one really that's a positive sweep test so that you can see what to look out for. Yeah, because what you're trying to do is push the fluid up here, and then you sweep it down, and then as you sweep it down, if there is fluid in the knee, then it will pop out on the medial side. Yeah, synovium is extensive, as we've said. Expansion of muscles reinforce anterior aspects. So you've got the quadriceps coming into here, which we'll talk about over the next couple of sessions. And then the synovial membrane has a pouch, which is called the suprapatellar bursa. So that's that area there. Okay, so or suprapatellar pouch. Even though the ACL and PCL are known as intra-articular ligaments of the knee, they sit outside of the synovial cavity. Okay, so yeah, bizarrely, the ACL, PCL are outside of this capsule. Okay, cool. There you go. There's a Baker's cyst. So the way that the Baker's cyst pops out, it looks like a speech bubble. Okay, so you get like a little tail, and then this pouch kind of area, and it's between your medial gastroc and your semitendinosus tendon, and that's where you'll see it pop out just there. So yeah, if you're having a look at the back of someone's knee and it's a bit swollen, then it may be a Baker's cyst, and if it is that, then there may be something going on inside the knee that is cause some kind of inflammation, and then come out into that space at the back. Cool. The other structures to look out for, I'm just going to make sure I've see what videos we've got left on this one. Yeah, cool. Okay, yeah. So the other structures we've got which can cause an issue. There's this one here called Hoffer's fat pad. May not have heard of this before, but Hoffer's, it can be confused for a patellar tendon problem. So this is Hoffer's fat pad just here, and it literally is just a bunch of fatty tissue behind the patella tendon. So there's your patella, there's the patella tendon coming down onto the tibial tuberosity. These are your meniscus, so these are your cheese wedges on your Trivial Pursuit. There's the articular cartilage there. There's a posterior fat pad as well, not as problematic as this one. And then you've got the pouch for the capsule just there. In fact, that's a really good picture. I'd never noticed that before. That there is a tiny little muscle, articularis genum. So its only job is to lift this pouch. Okay, so remember that pouch we were just talking about, where if there's fluid and you push the fluid up, then it goes into that pouch, and then you sweep it down to see if it comes out again. During movement of the knee, so during extension of the knee, what this muscle here will do is it will pull up on the pouch so that the pouch doesn't bunch up behind the patella. Okay, I've tried to look for it on cadaveric models, but it must be really, really small, or it just gets dissected out. But I've never seen it in the labs. Even when we did a dissection of a leg the other day or the other month, we tried to get down to that, but yeah, we couldn't see it. But so that's what that little muscle there is. So these are your quads just here, and this fat pad can get pinched behind your patella, and then it can get inflamed, and it can be a real literally a real pain. So and it usually hurts right here, which is where your kind of common jumper's knee is. Okay, so if you're doing loads of loading protocols and they're doing all their rehab really well, and you're thinking their tendon should be good, but they've still got pain, then it may be Hoffer's fat pad pinch that is causing the problem. Okay, so there's a lady called Claire Patella. Obviously, that's not her real name. I think it's Robertson. So Claire, I think it's Claire Robertson. But if you search for Claire Patella, she's got some really cool articles about how to rehab Hoffer's fat pad. So something to have a look at there. Okay, so that's just something else. So let's have a look at this. Just go back to this one. Yeah, these videos are killing it. Get rid of that. Get rid of that. Here we go. Okay, so this is your patella tendon, and there's your quads at the top. Okay, so quadricep tendon coming down into the patella just there, and then there's your patella tendon. So obviously there's no fat pad on this because it's a cadaver. So when people die, those kind of things go, but you can see the space behind the patella tendon. So just there, that's the patella tendon, and can you see that space behind it? So that space there, that will be filled with fat. Okay, and that's where your Hoffer's fat pad is. And there's a part of the capsule there, just there. Yeah, I agree, Martin. Yeah, I think Spanish squats are really good for that because it just avoids that pinching. So Baker's cyst is it's an inflammatory response to something that has happened within the knee. Let me just pause that there. So it's an inflammatory response. It'll be inflammatory fluid, but it'll be mixed with synovial fluid. But it comes from the synovial capsule. Okay, it comes from the joint capsule. So something in the capsule has been irritated. You get an inflammatory response. You get swelling, and then it's that swelling that then fills the capsule and then pops out the back. Okay, so there probably will be some synovial fluid within that as well. Let's just pop that back. Here we go. Yeah, this is really slow today. So there's your lateral meniscus. That's the edge of your vastus lateralis. So you can see that's where the suprapatellar pouch would be, just underneath there. Okay. And then that's, yeah, see that space there, that's where the Hoffer's fat pad will be. So that kind of triangular space behind the patellar tendon. I would try and point to it, but when I try and move my arrow on these videos, it doesn't move. Not today. Cool. Okay, so that's that. Hopefully that makes make a bit more sense. So it moves on here, fine. So this was that triangular space behind the patellar tendon that you just saw. Okay, and yeah, it's like I say, it's usually up around here where the patellar tendon gets the Hoffer's fat pad gets pinched. What you can do is put your thumbs either side of the patellar tendon, and then just push and try and squeeze that fat pad to try and elicit a response. So then you know you're off of the patellar ligament, patellar tendon, and then you're trying to get onto that Hoffer's fat pad, and usually in extension. Okay, so end range extension is usually when it gets pinched, because if this is inflamed, it gets caught between your femur and your patella. Okay, and that's the reason why. Usually it's some kind of like quick snap or something like that, and where you haven't really injured anything, but you've kind of knees kind of gone, and if it might feel all right for a couple of days, and then a couple of days later, that's when you start feeling it. Okay, so so that's Hoffer's fat pad. And then lastly, there was a question about bursa. You can't see bursa on cadaveric specimens because they dry out. Okay, so there aren't any images unless you get to see like a fresh dissection, which unfortunately we don't have access to. So we've got loads of bursa. Okay, so the articular capsule encompasses both the tibiofemoral and patellofemoral joints. So you've got the suprapatellar bursa, which is this one here. So that's that suprapatellar pouch that we were just talking about. And the articularis genum attaches onto the top of there. And so we were talking about that. You've got a popliteal bursa, which isn't listed on here. So that'll be around the back. Semimembranosus bursa, which is this one here. And then a gastrocnemius bursa as well. So basically, bursa are there wherever there is friction in the body, where two surfaces rub against each other. So and the body will develop them as well. And we've seen it a few times where you've found bursa in kind of weird places, in between semimembranosus, semitendinosus. There isn't supposed to be a bursa there, but I've seen one before. So it's basically like if you rub your hands together, it will create friction on the skin. But then if you put something in between and then do that, there's then no friction and it can carry on. Okay, no problem at all. So that's basically what a bursa does. So it provides this friction-free surface so that things don't rub against each other. Okay, and then bursa outside the capsule, pre-patella. So we've got this one here. This is the one that would be the problem with housemaid's knee. Okay, so again, if you've not seen that before, then have a Google of housemaid's knee. And it's quite common with gas fitters, plumbers, carpet fitters, those kind of people, where they're on their knees all day and they irritate this bursa, or they've had a bang. Okay, so they've fallen and banged their bursa, and then it just swells up huge. It goes absolutely massive. You've got the superficial and deep infrapatellar bursa. So we've got this one here. So between the patellar tendon and the skin, so subcutaneous underneath the skin. And then this one here, the deep one, is between the patellar tendon and the tibia. So again, we've got two bursa there to prevent friction of the patellar tendon against the structures that it's close to. Pes anserine bursa, and so that's this one here. So this is where several muscles will attach into this area here. And then on the lateral side, you've also got an iliotibial bursa, okay? And that links into something called the iliotibial band, which is this. Hopefully, there we go. We're back. So this is the iliotibial band. Now the iliotibial band, if you've never seen it before, is not really a band. So here is your tensor fasciae lata, just at the top there, and this is the fascia lata, which means white fascia. Okay, so the white fascia wraps around the whole leg. It's not just a band. Okay, so if you've seen me present this before, but I apologize, but this is your IT band. Okay, so there's the side of your leg. That's where your hamstrings would be. There's the back of your knee. There's your patella. And there is the band or the tract. Okay, so it's just a thickening of the fascia that envelops the whole leg. But that is not what you see. You see this. Okay, yeah, you see this band down here. That's not what it looks like at all. Yeah, it wraps around everything. So when you see it like this, it's because it's been cut. So somebody has taken a scalpel to the back and a scalpel to the front, and then they've peeled away those layers of connective tissue, the fascia, to reveal the muscles underneath, and then they've kept the iliotibial tract in place. And that's why we see this kind of image in the textbooks. Okay, but the iliotibial band isn't a band. There's Gerdy's tubercle, and then this is the kind of image that you'd normally see. Okay, so look at the difference. Yeah, so there's the actual iliotibial band, or the fascia lata, up onto the iliac crest. And then when you have the dissection done, that's what you see. Okay, so this area here, this is the thickened area of fascia of that whole band that wraps around the whole leg. How do you differentiate between Baker's cyst and bursa swelling posterior? It's the position of them. A bursa wouldn't extend as far as the Baker's cyst would, because that comes out really quite superficially. And sometimes it may be hard, and you just need imaging done to differentiate whether it's one or the other. You can quite clearly see a popliteal cyst or Baker's cyst on imaging, and yeah. So if you weren't sure if it was one or the other, then you just get imaging done to check out which one's which. So yeah, there's your IT band. This is the tendon of your biceps femoris. Okay, so you can see the attachment here on the fibula. We're just creeping into the muscles a little bit. Yeah. There's your vastus lateralis, biceps femoris tendon, and then that there, that's really cool. So this is the lateral intermuscular septum. So see that there. So this is like the compartments of the lower leg of the leg. So you know we've got all those different compartments: the anterior, the lateral, the deep posterior, superficial posterior, and then they're all divided by connective tissue, by lines of fascia. It's exactly the same in the thigh. So there is a very strong connection between your thigh bone, so your femur, and your iliotibial tract. It is connected directly into your femur, and it divides the back of the leg, so the muscles, so the hamstring muscles, from the front of the leg, which are your quadricep group. Okay, so there's a clear divide between the two, and very similarly, as in the leg, where you have a blood supply for a compartment and a nerve supply for a compartment, it's the same in the thigh. Okay, so that dividing structure there, this is where it's like your Trivial Pursuit cheese wedge. Okay, so you've got the kind of group of muscles all grouped together, and then it will come to a point. So the edges of the cheese will be your fascia, and then it will come to a point and attach onto the femur all the way up the thigh, all the way up and down. So that compartment will contain the muscles, the blood supply, and the the nerve supply for that group. Okay, so that's the dividing septum, which means hedge. Okay, so there's your dividing hedge, just there. So you can see here, so here we're back to the knee again. So there's Gerdy's tubercle, which is the attachment point of your IT band, and it'll be near there where the iliotibial bursa will be. Here's your glutes. Okay, so glute max. TFLs, tensor fasciae lata at the front. So tensor fasciae lata is the tensor of the white fascia. And the reason why this bit is thickened is because of the pull from the tensor fasciae lata and the glutes on that particular part of the connective tissue, and then this then starts to thicken. Okay, so that's why that bit's thicker than any other bit. And then that's where it attaches up here. And you can see it just literally just merges. So it's like a really, really long tendon. Okay, so that is your IT band, which looks nothing like the IT band that you see in books. Cool. What time are we at? Perfect. Right. Let's have a look at this next bit. So that's all your passive structures. There's then just this one kind of interesting structure that you may or may not have heard of before. It's called the fibella. So the fibella is here. Okay, right here. So there's your patella, your femur, and your tibia. You've got fibular head just at the back there. So the fibella is a sesamoid bone, sometimes present in the tendon of origin of the lateral head of the gastrocnemius muscle. So there's a bit of bone at the back there, and sometimes people have it. So if you do soft tissue treatment and you're massaging someone's calf and you're trying to massage out a knot, have a little bit of a think, because it may not be what you think. It may be a bit of bone that you're trying to massage out, which might will be quite painful. So yeah, there's something called the fibella, and sesamoid bones are there to help increase the efficiency of muscles. So like with the patella at the front. Okay, so the reason why that would be there is to improve the efficiency of that gastroc for whatever reason. Okay, so I know somebody did ages ago did some little research about the fibella. So if you search in the group, the Learn Anatomy Online Facebook group, then you may you may see what somebody else has already started. Okay, but just an interesting one, I thought, that you might not have heard of before. So yeah, sesamoid bone that sits in the tendon of gastrocnemius, thought to develop because we're taller and heavier than 100 years ago. The prevalence between 3 and 87%. So there's quite a wide range there. The median rate is around 30%. So 3 in 10 roughly are going to have a fibella. No difference between genders. Remember what the patella does to the forces generated by the quadriceps. So the fibella is purported to do the same. Okay, there you go, there's the paper. So fibella prevalence rates increases over 150 years, and rates of other sesamoid bones remain constant. Okay, so that's quite interesting. So, but most other, so if you remember in the foot, you had sesamoid bones in the big toe. You've got your patella, which is a sesamoid bone, and now you've got the fibella as well, which you may or may not have heard of before. Cool. Okay, so let's have a little bit of an introduction into some of the muscles of the knee. So anything that is genicular basically comes from Latin, which means knee. Okay, so knee is geniculum, is genu, is genicular or geniculate, genum. There's loads of different terms that are used. Anything with that in basically is related to the knee. Okay, so hopefully that will help. So we're going to have a look at some of the muscles from the leg. So from the lower part of the body, which we've covered already, looking at, or some of them we have, looking at the ankle, and but they also cross the knee. Okay, so we've already been introduced to these before. So one of them is gastrocnemius, which we have seen before, because we looked at this in the ankle and the foot. We looked at the Achilles tendon, and then we just briefly mentioned the fact that they cross the knee. The soleus isn't included in this because it doesn't cross the knee, okay, but the gastrocnemius does. So yeah, posterior, lateral, and medial condyles of the femur is the one of the attachment points, and then it goes down onto the calcaneus. Okay, so around here. So let's have a look at the top part of that. Just get that video up from the leg, gastroc. Here we go. From the leg, gastroc. Hopefully it's that one. Just sort all those out. Okay. Get rid of those. Here we are. Okay, so gastrocnemius, here we go. So first muscle that we're going to look at around the knee area. If I just pause that there. So there's your Achilles tendon. So this is the bit that we were interested in last time. And now we're interested in the bit up here. And this is near where your Baker cyst will come through if you have a Baker cyst. There we go. Just play that. So those bits there are more kind of tendinous areas. I think we talked about this before. There's your soleus underneath. And then there's the gastroc as it's coming up here. You can see both of the heads there. They kind of reach up and then grab onto the femoral condyles just up there. Look, there and there. Okay, and then this was the bit that we were talking about before. So this is the musculotendinous junction where it turns from your Achilles into the gastroc. You can see soleus underneath. And then goes down into the Achilles tendon. Okay, so we've seen all that one before. So the bit that we were interested in there, that for this particular section, there's more action going down at the ankle with this muscle, obviously. It's a very, very weak knee flexor. Okay, so because of the position of the attachments, it will help with flexion of the knee, but it's weak. Yeah, so it's not as prevalent as some of the other bigger muscles like the hamstrings, for example. Cool. And I think that will do for time. So we've got next week, we've got just go over these popliteus. So we'll have a look at that one, and plantaris. Okay, so we'll have a we're starting to cover some of the muscles around the knee now. So this might be stuff that you're more used to hearing about. Cool. Just get rid of that. Perfect. So that's your passive structures done. So we've had a look at all the ligaments. We've had a look at the bursa. We've had a look at the meniscus. Talked about the joint capsule. Talked about the fat pads that are around the knee as well. So hopefully you should have a really good idea about all the different structures around the knee. We've then starting to layer on the muscle tissue. Okay, so all the stuff that's on top of that now. Have a look at all the active structures. So passive structures, just they don't contract. The active structures they do, which is what we'll have a look at next. Okay, cool. I will see you next Monday at 10 o'clock. See you then.